Good morning, everyone, and welcome to our event today. This roundtable will feature Dr. Yamshon, Dr. Hilal, and Dr. Rutherford. My name is Kat, and I am the HealthTree Health Education Manager for Lymphoma. I'm so grateful to have all of you here today and joining us to help build a stronger community. I'd like to let you know that today's session will be recorded, and the recording, along with any slides that are shared, will be sent through email to all registrants within 48 hours after the event has concluded. Before we get started, I'd like to thank our sponsors, Regeneron and Bristol Myers Squibb, who made this event possible. And the topic for today's event will be understanding follicular lymphoma. This is an idea of what the agenda will look like. I'll give an introduction to our speakers, and then they will spend about an hour giving their presentations. After the presentations, we'll open it up for a Q&A portion where anyone can ask a question in the chat, the Q&A chat, and any doctor can answer them. I'll start by introducing Dr. Hilal. Dr. Yamshon, sorry. Dr. Yamshon is an assistant professor of medicine, and he is the director of cellular therapy at Weill Cornell Medicine, New York Presbyterian Hospital. Dr. Yamshon cares for patients with blood cancers with a specific focus on lymphoma and improving outcomes for patients using innovative treatments like cellular immunotherapies, including CAR T-cell therapy. Dr. Yamshon received his BA from Columbia University and completed his medical training at the University of California, Davis. He returned to New York to train in internal medicine at Weill Cornell Medicine, where he also completed his fellowship in hematology and oncology. At Weill Cornell Medicine, he specializes in treating patients with lymphoma using cellular therapies, including bone marrow transplantation and CAR T-cell therapy. He is involved in clinical research dedicated to improving outcomes for patients with lymphoma. He has been involved in lymphoma research for over a decade, co-authoring numerous publications and several presentations at national meetings. Dr. Yamshon is also an editorial fellow for the journal Leukemia and Lymphoma. He has received multiple research grants, including the American Society of Clinical Oncology Young Investigator Award and the Lymphoma Research Foundation Scientific Research Mentoring Program. Next, I'll introduce you to Dr. Hilal. Dr. Hilal is a hematologist oncologist and bone marrow transplant physician with a clinical focus on chronic lymphocytic leukemia, lymphoid malignancies, and rare histiocytic neoplasms. Dr. Hilal attended medical school at the Royal College of Surgeons in Ireland. He obtained training in internal medicine at the University of Kentucky and in hematology oncology at the Mayo Clinic in Phoenix, Arizona, where he served as chief fellow. Dr. Hilal's clinical practice focuses on the treatment of chronic lymphocytic leukemia, various types of lymphoma, and histiocytic neoplasms. He is interested in incorporating various modalities of therapy that help serve individual patient needs, including using novel targeted therapies, bispecific T-cell engagers, and cellular therapy. He is part of the bone marrow transplant and CAR T-cell therapy programs where he prescribes specialized treatments for patients with lymphoid malignancies. And finally, Dr. Rutherford. Dr. Sarah Rutherford is an assistant professor of medicine in the Division of Hematology Oncology at Weill Cornell Medicine. She is a graduate of the University of Virginia School of Medicine. She completed internship and residency in internal medicine at Thomas Jefferson University Hospital in Philadelphia and fellowship in hematology oncology at New York Presbyterian Hospital, Weill Cornell Medical College. Dr. Rutherford has clinical expertise in lymphoma. Her research focuses on improving outcomes in patients with aggressive lymphomas. She has particular interest in helping patients to have an accurate understanding of their diagnosis. She has received honors from Weill Cornell Medical College and the American Society of Hematology, and support from the New York State Empire Clinical Research Investigator Program for her research in diffuse large B-cell lymphoma. She has experience in caring for patients with a variety of lymphomas and hematologic disorders, including Hodgkin lymphoma, chronic lymphocytic leukemia, diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, and marginal cell lymphoma. Thank you all so much for being here today and sharing your expertise with us. With that, I'll turn the time over to Dr. Yamshon.
Good afternoon, everybody, and thank you for being here, and thank you to Kat for the invitation today. I'm looking forward to speaking with all of you and those who are watching later and recording a little bit about follicular lymphoma. I actually think that understanding follicular lymphoma requires us to take a little bit of a step back, because I think that understanding lymphoma, I think, requires an understanding of kind of the immune system in general. And so our bodies are constantly fighting off invaders. And those invaders can come in a lot of different shapes and forms. Those can be viruses, those can be bacteria, those can be parasites or fungi, and they can actually even be cancers. And our body has a lot of different tools to fight those infections. And it's almost like having, the Army, the Navy, the Air Force. And our body is constantly sending out signals to kind of direct all of those different forces in our body. And so when a threat comes, say when you get the flu, the body sends a signal to our immune system that says, immune system, we need you to recruit. And those cells recruit, and they go and they kill off the threat, and then the threat is gone. And critically, the body sends another signal to those cells that says, thank you for defending us. We don't need you anymore. Please go home. And those cells disperse over time. But sometimes those signals get broken. And for whatever reason, either the body forgets to send the signal telling those cells to go away, or those cells, the body's sending the signal, but those cells just don't hear it properly. But either way, the cells kind of don't hear the message to turn off. And so they continue to grow even when they're supposed to go away. And I think that is kind of a good way of thinking about how you get a lymphoma, which is immune system cells that just aren't getting the message to go away. So there are actually many different types of lymphoma that come from different places where the signals get broken. There is, a split between Hodgkin and non-Hodgkin lymphoma, which you may have heard of. There are lymphomas called B and T cell lymphomas. And there are also aggressive lymphomas. But in the case of follicular lymphoma is a lymphoma that arises out of a type of immune system cell called a B cell that is what we call an indolent lymphoma, which means that it is slow growing and generally speaking does not grow very quickly. And in the case of follicular lymphoma, arises out of particular cells that come from a place in the immune system called the germinal center of the lymph node. Now, because of that place where it comes from, follicular lymphoma tends to grow in our lymph nodes, although it can, in theory, grow elsewhere and sometimes does. But so our body has a bunch of lymph nodes kind of throughout, and those are almost like command centers that the body uses as a place where it can fight infections. And so when the lymphoma cells in those germinal centers stop hearing the signal from the body to go away, they continue to grow. And so over time, they generally speaking grow in lymph nodes. Now, as I said earlier, follicular lymphoma does tend to grow very slowly. And actually, I find in my practice that many patients, and perhaps even the majority of patients, they discover their lymphoma almost by accident, that they are getting a scan for some other reason, say, they have a cough and they get a chest X-ray, and that X-ray shows a swollen lymph node, or they're undergoing a routine colonoscopy, and something is seen in the colon that was unexpected. But because follicular lymphoma grows so slowly, it oftentimes doesn't cause any problems at all, and people actually don't necessarily notice that they have it. Many are found by accident. Other times, patients may notice that they have a swollen lymph node, and again, because these do tend to grow quite slowly, people may take a while before they notice something, or they may notice that there is a small bump somewhere that they don't really think anything of, and over months or even years, it grows into something a little bit larger, and that is very common in follicular lymphoma. Other times, people do notice something, and we'll get into a little bit more about what some of the more common symptoms are. But I think, generally speaking, it's very common for people with follicular lymphoma not to know that they have it until it's discovered for some other reason, and that can sometimes be a little bit of a source of consternation. I would have never known that I had this, and so that is something that is quite common amongst patients with follicular lymphoma. So a question that comes up quite often is, what are some of the causes or risk factors for developing follicular lymphoma? I think that there are some risk factors that we know of, and some other risk factors that I think we're still learning about. But there are some that I think are modifiable, meaning that there are things that are things that people can know about and perhaps intervene upon, and others that are not really what we call modifiable risk factors, meaning things that people can change. They're fixed. So one of the most I guess the most important risk factors for lymphoma in general, and I actually would say for cancers in general, is age. So the older that you get over time, the more chances there are for some of these immune signals to get disrupted. And so as you get older, there is an increased risk, but follicular lymphoma and other lymphomas do occur in younger people. There does appear to be a bit of a racial distribution. So in the United States, for example, white patients are more likely than African Americans and Asian Americans, for example, to develop non-Hodgkin lymphoma in general, and kind of by extension follicular lymphoma. And I think as of now, we have somewhat of a poor understanding of why that might be, but that is something that we've noticed over time, and is a known risk factor. Worldwide, interestingly, non-Hodgkin lymphoma in general, and again by extension follicular lymphoma, is more common in developed countries, with the United States and Europe having some of the highest rates relative to some of the other countries around the world. So family history is a question that we get asked a lot. Having a first-degree relative, meaning a parent, a child, or a sibling with a lymphoma, does appear to increase the risk of having a lymphoma yourself slightly. But there's some controversy as to whether that actually it has to do with genetics, or whether that has to do with the fact that most of the time with a first-degree family member, you're often exposed to the same environment over time. And so generally speaking, it's kind of an unclear risk, the degree to which family history plays a role. Some studies have shown that certain chemical exposures increase the risk of follicular lymphoma. Exposure to benzene and certain herbicides or pesticides. For example, I think the the one that people hear about the most is Roundup, and you may see some of those commercials on television. Have you been exposed to Roundup? And that the link between those exposures and the risk of non-Hodgkin lymphoma in general, and again follicular lymphoma specifically, I think are there's some mixed results from some of those studies, and so I think in general we think of those as potential risk factors, but are not totally clear, and I think that research to clarify those links are still ongoing. Similarly, I think military exposures in particular, such as Agent Orange or burn pits. Agent Orange, we do know, is associated, and burn pits actually is an area of ongoing research. Some of my colleagues through the VA in particular are looking into this now, but for now it's somewhat of an unknown. And we also know that exposure to, for example, exposures related to 9/11 may also have played a role. And I know that Dr. Rutherford and I both have seen patients who were either first responders or lived in the area near 9/11 in New York City and potentially was a driver of their lymphoma. Similarly, we know that radiation exposure does increase the risk of development of cancer in general and by extension lymphoma. And then I think the other critical risk factor that we know of is having an autoimmune disorder. I think we know plays some role. I think the one that is most well described is Sjogren's syndrome, but I think that autoimmune disease in general potentially does play a role in lymphoma development. And I think when you take a step back, that makes a lot of sense, because we know, based on the discussion earlier, that lymphomas are driven by a disordered immune system. And so I think that is a something that we know may drive the development of lymphomas in general. So the last thing that I want to talk about before I turn the floor over to Dr. Hilal is just symptoms of lymphomas in general. So I had mentioned earlier that many and perhaps even the majority of patients with follicular lymphoma will initially have no symptoms at all. When patients do develop symptoms, I think most of the time the symptoms are driven by where the lymph nodes that have grown are located. So either discomfort from one of those lymph nodes or the lymph node pushing on something else. Patients that come to mind are I have a patient now who has some lymph nodes in her abdomen, and so so she had her initial presenting symptom was abdominal discomfort. Other times, if there is follicular lymphoma that develops in, say, the lung, one might develop shortness of breath. I think it's generally related to where the lymphoma involvement is, or discomfort from the lymph node. And then as symptoms, as follicular lymphoma grows, patients can develop symptoms that are related to those lymphomas. And that's kind of a constellation of symptoms that historically we call B symptoms, which are fevers and chills, drenching night sweats, weight loss, and fatigue. And so developing some of those symptoms may portend that the lymphoma is growing. And generally, as I know that Dr. Hilal and Dr. Rutherford are going to get into, are reasons to treat the lymphoma to help with getting rid of some of those symptoms. And so with that, I'd like to turn the floor over with Dr. Hilal. Again, thank you all very much for having me, and I'm looking forward to the Q&A session later.
Thank you so much. Thank you for inviting me to speak here, and thank you for this great introduction on follicular lymphoma. So my job was to kind of cover a little bit about how does diagnosis happen, staging, grading, and how do we think about what we need to do with treatment. I think there's a little bit of overlap there with what Dr. Rutherford will be covering. So um, I will present some slides. I think putting that sort of image might be helpful. So let me make sure I have the right view. Okay. All right. So to diagnosis of follicular lymphoma, like most cancers and most lymphomas, requires a biopsy. And ideally, we like to get a decent enough sample. And so, incisional biopsies or an excision of a full lymph node are ideal to really give you a good idea of, is there enough involvement of the same type of lymphoma? Do you have another lymphoma in that lymph node? And there are some risks associated with transformation of follicular lymphoma into a more aggressive subtype. And so those are things that if we are suspecting, we would like a large sample. Usually with follicular lymphoma, what you will see is follicles containing small cleaved cells, and sometimes you'll see larger non-cleaved cells to a lesser degree. The amount of these larger non-cleaved cells in the actual lymph node really determines a little bit how we grade them. They all have this genetic alteration that really triggers the development of the lymphoma. And as Dr. Yamshon covered, we don't really know what really triggers it, but there are some risk factors out there. 85% of people with follicular lymphoma will have this genetic alteration where a chromosomal abnormality of 1418. Most patients have what we call classical follicular lymphoma, and this is sort of a new terminology that is being used by the World Health Organization's latest update on lymphoma. And so what you see is these sort of round follicles on a low power view under the microscope inside a lymph node. And if you really zoom in, you see these small cleaved cells. So you'll see something in there, and that's the typical follicular lymphoma morphology. If you start counting under the microscope how many of these larger cells exist, then you kind of start grading the lymphoma. So grade 1s and 2 are considered low grade. 3A is considered low grade, and those usually have a smaller amount of what's called centroblasts. When you start seeing larger amounts of these centroblasts, larger cells, then we grade it as grade 3B. And the distinction there that has to be made is this really a follicular lymphoma now, or is this what's called a diffuse large B-cell lymphoma, which is more aggressive? Now, what's interesting over the last few years is some newer criteria have come out that really put in question the utility of this grading system. We know that follicular lymphoma grades 1 through 3A really behave similarly. So you might have, really what's called grade 1, very, very low grade lymphoma, and do just as well as someone with a grade 3A. And so the question then is, do we really need to grade it? And so in the World Health Organization's newest update, it's not mandatory to do that anymore. There are a lot of logistical issues as well with it. There's a lot of differences in, the pathologist looking under the microscope, and there are differences sometimes between these grades, depending on who's looking at the slides. Now, the other classification system does maintain that grading may be useful to report, but we still really don't think that prognosis is very different between grades 1 through 3A. 3B does behave differently, and 3B does require treatment that usually is tailored towards a more aggressive subtype of lymphoma. And this again kind of gives you maybe a little bit of a picture of, grade 3B. The cells are larger compared to what you see here on the left. The cells are more round and sort of smaller, darker blue here, and here they're a little bit larger, paler cells. So that's one aspect of it, and you require a large sample of tissue to determine grading. The next step is stage. And with lymphoma, most common question I get is people asking, what is my stage? And most people's interpretation, perception of what stage is may not always apply in lymphoma. So if you think of stage 4 disease, meaning it's in multiple parts of your body, including outside the lymph nodes, in the bone marrow, potentially, maybe in organs like the liver or the spleen, um, that actually is the most common presentation of follicular lymphoma, in addition to stage 3. So when you think about advanced stage disease, it is the most common thing we see. And that does not always mean you have, sort of terminal cancer, if you will, when you think about a stage 4 breast cancer or a stage 4 colon cancer, where the goals of therapy are very different. With follicular lymphoma, the norm is stage 3 and 4, and only about 20% of people will have, really early stage 1, 2, and maybe found incidentally. And this has bearing on treatment a little bit when you have stage 1 disease, but really not so much when you go into advanced stage disease. If you're asymptomatic and you have low volume of disease on imaging, it doesn't really necessarily change how we approach the treatment. It doesn't necessarily change prognosis too much either. And this really kind of survival, a cohort of about 1,000 patients showing survival data of stage 1 in the red line here versus stages 2 through 4. People do well in general, with usually about 80% or so alive at 10 to 15 years, and this is a pretty decent follow-up period. There's a lot of people that don't get followed up that long, so we really don't know how they do. Most commonly, they do just as well. But you can see that there is a grouping, stage 1 versus the others. And this might have some implications on treatment that I think Dr. Rutherford might get into. So how do we stage in general? We used to do CT scans, do chest, abdomen, pelvis with IV contrast, bone marrow biopsies. Nowadays, a PET scan often is enough to tell you a lot of what you need. So it can actually comment on whether you have disease in the bone marrow without doing a bone marrow biopsy. It is not 100%, but it sometimes kind of allows us to avoid putting patients through invasive procedures. But those are usually the types of tests we need. Now, when it comes to risk stratifications beyond grade and stage, there are many models out there that are trying to kind of tell us up front. They were developed, over the last 20 years to try and tell us up front, if patients are newly diagnosed with follicular lymphoma, can we predict how long they're going to live based on multiple factors? And so this is the most commonly used one. It is somewhat outdated, now 20 years old. And it was at an era where we didn't use some of the therapies we have today. So I'm not sure how applicable it is nowadays, but you'll still hear about it and come across it. It's called the Flippy score. And it really takes into account age, stage, how many nodal sites are involved, and other blood tests, hemoglobin, LDH, markers that might tell you a little bit about prognosis. And if you have 0 or 1 of these, you fall into this low risk category. If you have 2, you fall into the intermediate risk category. If you have 3 to 5 of these parameters, then you're in the high risk category. Again, this is a very rough, sort of very poor man's way of predicting things, but it's something you do come across when you're reading about follicular lymphoma. And I think from our perspective, we typically don't put as much weight on it. And I think individual patients will really behave very differently, when you start their treatment and see their disease course. And we've seen patients who may not necessarily have what's called high risk flippy and still have relapses sooner than we might expect. There are other models out there that came out that are trying to refine the flippy score. Flippy 2, trying to incorporate bone marrow involvement, the size of the lymph nodes. This was validated at an era where we're using rituximab, which is an anti-CD20 antibody that targets B cells. There are other models that integrate molecular features as well. But I will say in general, for all of these models, they remain imperfect, and they're very hard to apply to real individual patients to tell us how individual patients are going to do. So I'm going to sort of end with just a few more comments here. large sample of tissue is essential, and you might encounter situations where we get a small sample and we're not sure if this is all follicular lymphoma or could there be something else there that's more aggressive. And so it's not also uncommon that I often encounter situations where we have to refer patients for biopsies more than once. Higher grade, especially grades 3B, indicates worse prognosis, and that's the grade where we might need to change therapy and use therapy that really is usually often reserved for more aggressive B-cell lymphomas. Follicular lymphoma in general is very heterogeneous. We have a portion of patients who progress quickly within 2 or 3 years. Those patients typically have a more aggressive disease course, and they do require more novel therapy approaches, and potentially even more aggressive therapy approaches. There are a portion of patients who have long-term remissions and really never relapse after one line of therapy. And then we have a decent portion of patients that are alive at 10 years, and if they don't relapse within the first 2 to 3 years, might actually have overall survival that is similar to the human population that don't have follicular lymphoma. So it's very hard to predict upfront who's going to fall in any of these categories. And so a lot of times we just need to follow patients closely and make determinations on when when we think we're concerned about their follicular lymphoma versus when we can space out the visits and make these follow-up visits less frequent. So there is no great way up front, I would say, but we have some tools that we can sometimes use that can kind of give us a little bit of clues. So I'm going to stop here and hand it over to Dr. Rutherford, who will, I suspect, discuss issues related to therapy and when we initiate therapy.
Thank you so much, Dr. Yamshon and Dr. Hilal. You all have done a great job, and I think really set me up well to do the part that's the most exciting. And thank you, Kat, and to the group for inviting us. We really love doing these types of events, and we're excited to be able to help you and answer your questions too. So as has been said before, I think one of the very key aspects of management of follicular lymphoma is to determine if treatment is indicated. So at this point, I'm going to describe as if you were a patient coming in to see me, and we know that you have a diagnosis of follicular lymphoma. So first of all, I do like to know where the disease is, as has been mentioned by Dr. Hilal just now, ideally by a PET CT scan. And part of the reason that's helpful is because it tells us exactly where the disease is, how large the lymph nodes are, for example, if there's involvement in areas like occasionally we see lymphoma in the fluid around the lungs, and that causes shortness of breath and can really be a reason that patients need treatment. I agree with what he said about really rarely needing a bone marrow biopsy, and that's been something I'm actually very interested in from a research standpoint as well, that we really don't need to do bone marrow biopsies in most cases because it really doesn't change the management. The one exception to that, as Dr. Hilal mentioned, is that if we do suspect that the lymphoma is just in one place, like say just in the neck, then we often would do a bone marrow biopsy to confirm we don't see bone marrow involvement. And then we can do radiation treatment, which is done in a strategy to try to cure a patient. But in reality, it actually is usually probably somewhere else that we just didn't detect. Like, for example, I have a patient who had radiation a few years ago to one area, and then it did recur somewhere else. So it actually is completely accepted, even in stage 1 disease, to monitor patients closely without treatment if we don't think that they have any other indication for treatment. So let's say the majority of patients do have disease in more than one place, advanced stage disease, as Dr. Hilal said. So now it's up to your doctors and you together to help determine whether treatment's indicated. So there are actually a couple different scales or criteria that have been created in an effort to streamline and make it more objective for doctors to determine who needs treatment. I will say that each person is their own unique entity and may not apply exactly to this criteria, but at least we have some guidelines. So potential reasons for treatment would be, one, if you have symptoms that we think are related to the disease, like fatigue, though that's very difficult sometimes to determine if that's really due to lymphoma or some other reason, since a lot of people complain of fatigue. Decreased blood counts, particularly large size of lymph nodes. So one of the criterion is 3 different lymph nodes that are 3 centimeters or greater, or if you have one particularly large lymph node. I have a patient recently who came with a 10 centimeter lymph node in the abdomen. That's very clear indication for treatment, because there's concern that that could interfere, one, cause pain, but also interfere, for example, with the drainage of urine into the bladder. So that large size of lymph nodes is a reason for treatment. Unintentional weight loss is another one. But like I said, it's actually quite subjective in many cases. And so what I'll tend to do, if I'm not really sure that a patient needs treatment, I'll watch them really closely. I mean, that's what I do in general, but I'll see them every 3 months at least. I think one of the keys for you all to be aware of is that you really need to keep in close touch with your doctor. That's one of the really the ways that this active surveillance or watch and wait type approach works is because if there's a change, you need to tell your doctor, or we need to be seeing you frequently enough that we're going to pick something up and be able to act on it if it does happen. That being said, this is a slow growing disease. So if we're watching you carefully, usually we're going to catch some subtle changes before it becomes, a more symptomatic type issue. So one key point that I think is brought up already, but just to really make you feel comfortable with this, because it's often strange for people to come in and hear that they're going to be monitored closely without treatment. I mean, some people really like that, but other people get nervous, like, why are we not doing something about this? And it's because there's really never been any proof that by treating you really aggressively up front that you're going to live longer. So our goal is really for you to live as long as possible, feeling the best way possible. And one key reason in the last 10 years or so, we've had so many new therapies approved that if I had treated someone 10 years ago, I would have treated them with maybe an intense chemotherapy regimen that I could avoid now, because we have a really exciting clinical trial with a newer therapy that I'll tell you about in just a minute that we think may work better and be safer than chemotherapy. So especially in this era of having so many new drugs coming out, we have every reason to wait and sort of hold on to our treatments until we really need them. And often people can live years without even needing any treatment. So now if we do decide that treatment's indicated, the approach really needs to be tailored to the individual patient. So one strategy that I really favor that we use often at our institution is single agent rituximab. So rituximab is a immunotherapy. It's really the first, in some ways, immunotherapy that was approved about 20 years ago for follicular and other non-Hodgkin lymphoma. And it binds specifically to lymphoma cells by a protein on the surface of them called CD20. That's a B cell lymphoma marker. And it's very effective, even in given by itself. 4 weeks in a row. That's the whole treatment course. It's really pretty minimally disruptive to people. It doesn't cause that many symptoms. So usually people can continue working the regular schedule. They don't have many side effects. A couple of side effects to be aware of is that it does commonly cause a shaking chill-like reaction the first time we give it. So we usually give Benadryl and steroids to try to avoid that. And I find people actually feel more symptoms from the Benadryl and steroids than the rituximab itself. We give it very slowly the first dose, usually over 4 to 6 hours. If people do get a shaking chill reaction, nurses are very comfortable using this regimen because it's been available for so many years. So we'll stop it. We'll do some interventions such as giving more steroids to help get the reaction under control, and then we'll restart it at a lower dose, a lower rate. The other issue to be aware of that I think we have been concerned about, particularly during the pandemic, is that it can increase your risk of infections. It tends to be viral infections that people are more at risk for. So that would be a reason why. So in the past, and I know some hospitals do this, but we tend at our institution to just give the 4 doses and then monitor people closely without additional treatment as long as the patient has responded well to rituximab, meaning as long as it's worked. If you give ongoing rituximab, say every 2 months for a year, an additional 4 or 6 doses, that actually can really cause people to be more susceptible to infections. And I have seen that even in recent months with people who got maintenance rituximab, that they were having more severe COVID infections. So I really tend to just give the 4 doses. And then we usually do another PET scan about 6 weeks after the treatment to assess the response. And if the treatment has worked, then we go back to a surveillance mode of monitoring them every 3 months. And I do want to note that we tend to not do that many imaging tests for these patients because we're monitoring them so closely and we're expecting them to live hopefully decades. We're trying to minimize the issues associated with frequent scanning. So increased radiation exposure, anxiety, costs. There are a lot of reasons to try to minimize the amount of scans. And like I said, if you're following patients really closely with physical exams, labs, and just getting the history frequently, usually you can pick up on some subtle sign of the disease acting up. And at that point, you can order a scan and assess where we stand. So let's say I'm following a patient who's gotten rituximab, and 2 years later, they start complaining of feeling full more easily, or they're losing some weight unintentionally. I might say, okay, let's do a scan. Let's see where we stand. And this actually just happened to me this week. So this patient is having some subtle increase in their lymph node size, and actually could continue to be monitored. But if it's been 2 years or so since they got rituximab as a single agent, you could absolutely use it again. It's so well tolerated, again, minimally disruptive to people's lives. Is cumbersome to come weekly for a month, but then that's it. So definitely can use that again. But I do want to be honest with you that there are some times when patients present with sicker situations. So sometimes people actually present to the hospital with shortness of breath or abdominal pain or symptoms like that are concerning concerning when we start working them up, that they're someone who needs a faster response. So when we use rituximab, it usually takes somewhere in the order of 2 or 3 months for them to really get a full response from it. So if someone is acting very symptomatic, we usually incorporate a chemotherapy drug, often bendamustine, which is a drug that's given 2 days in a row every 3 to 4 weeks for 6 total treatments. So it's close to a 6-month course. Actually a very well tolerated drug. I have an older patient who I'm about to start that on, and we can dose reduce it for older people to better tolerate it. Or we can give it just on the one dose per cycle instead of 2. There are lots of ways to really modify this to help older patients tolerate it well, because as Dr. Yamshon mentioned, many of our patients are older, and we really need to balance the risks and benefits of the chemotherapy and make sure that we're getting you feeling better and not making you sicker. So I find that bendamustine rituximab is a very well tolerated regimen. It can decrease the blood counts, as can any treatment for lymphomas and other malignancies, but we typically use an injection that we call Neulasta. That's the brand name. There's other generic versions of it that's given either in a patch form on the 2nd day and injects the 3rd day, or patients need to come back the day after treatment to get this injected, and it helps to boost the white blood cell count in between treatments and minimize the risk of infection. That drug can cause bone pain, so we do need to be cautious about that. I sometimes think the side effects from this Neulasta are actually worse than chemotherapy, and so you need to be in close touch with your doctor and come up with strategies to help. We usually recommend, if you have normal kidney function, taking a drug like naproxen or Aleve is really helpful to manage this bone pain, which typically happens about a week after the treatment. So let's say a patient is getting a bendamustine and rituximab regimen. I usually repeat a scan after 2 to 3 cycles to make sure the treatment is working. We finish up the 6 cycles. And at our institution, we usually we don't continue giving rituximab in a maintenance strategy. Maintenance means you're giving like 1 dose every 2 to 3 months for another couple of years. But I've already addressed that and told you that that is an option, but it's one that I don't tend to favor because I don't think there's a lot of benefit out of it. I think it's more likely to cause increased risk of infection. There is another monoclonal antibody that's newer, like rituximab, but it's called obinutuzumab, and it is given it can be given in a similar strategy. It's not approved to be given as a single agent by itself. It can be given with bendamustine or other chemotherapies such as CHOP. So I do want to mention, as Dr. Hilal has said, that there are times when we are concerned that follicular lymphoma has transformed into a faster growing lymphoma. And sometimes we can't prove that. So say our goal when we do a PET scan is to identify the lymph node that has the highest activity, that's the easiest to get to from a biopsy standpoint. But sometimes the highest activity one might be really hard to get to, and it might be not worth the risk of a surgery getting deep into your abdomen to prove that the disease is a more aggressive version. And when that happens, we actually usually recommend the more intense chemotherapy regimen called CHOP, which is really one of the standard, for many years has been the standard for a different disease called diffuse large B-cell lymphoma. And that's 4 chemotherapy drugs: cyclophosphamide, doxorubicin, vincristine, and prednisone, that are given every 3 weeks for 6 cycles. So if we're concerned that you might have a more aggressive component, we will sometimes use that regimen instead of the bendamustine. It's actually quite well tolerated. We use it very frequently in this field and have a lot of experience with it. One difference between bendamustine and CHOP is that CHOP does cause hair loss. And so we always want to be forthcoming about that, because that is really hard for a lot of people. And we do, we are able to provide prescriptions for wigs, or sometimes we call them hair prostheses, but head prostheses. But that, it is okay to feel bad. Some people are embarrassed to say that they're upset that they're going to be losing hair. It's completely normal. Most people do feel that that's really a downside of some chemotherapies. So it's an upside of bendamustine that it actually doesn't cause that. Okay, so what I'm going to tell you about now over the next 5 minutes or so are some treatments for when the lymphoma recurs after some of these standard frontline therapies. So the most commonly used drug in someone who's already gotten rituximab and one of these chemotherapy agents is called lenalidomide or Revlimid. It's an oral drug. We have a lot of familiarity with it because it was originally approved for multiple myeloma about 20 years ago. And now it's approved for a number of different lymphoma subtypes. It works really well. It's given orally basically daily for 3 weeks, and then off 1 week, and cycles, varying schedules between 1 to 2 years. It's usually given with rituximab or obinutuzumab too, and that the other drug would be given about once a month for 6 cycles. I can repeat. I know I'm giving you a lot of information. I'm happy to repeat this later if you'd like, and I'm sure that some resources can be provided to you if you need more detail. But basically, this drug, lenalidomide, works very well. It's commonly used in people who've already had chemotherapy. It's technically approved for newly diagnosed patients who haven't been treated before. Its side effects include decrease in blood counts, and which can make you more likely to have infection. We do sometimes use those injections like Neulasta to help boost the white blood cell count. We can transfuse people. There's another injection that can boost the platelet count if needed to help manage side effects. That drug can cause a rash and also diarrhea. But generally, we're good at managing these type of side effects because we have a lot of experience with this drug. So if that type of issue comes up, you just let your doctor know right away, and they'll help you with steroid creams or some occasionally oral steroids or Imodium if you had diarrhea, for example. Now, what's most exciting to me are the newer agents that have been approved just in the last year, and those are immunotherapy type strategies. One is called CAR T-cell therapy, and the other is called bispecific antibody therapy. And they're really revolutionizing the treatment of follicular lymphoma and diffuse large B-cell and other lymphoma subtypes. So basically, the rationale, and I think probably my colleagues here can explain this even more clearly than I, because I think they both administer this themselves. Whereas for me, actually, I work really closely with Dr. Yamshon at Cornell. So if I have a patient that I want to get CAR T-cell therapy, I actually refer to him, and he's right down the hall, and we'll see the patients and we'll coordinate working on this together. But basically, the way that the CAR T-cell works is that you would have blood collected, and your T cells specifically would be collected and then sent to one of the companies who's has, if you are in the US, that is, who have FDA approval to manufacture these T cells. It usually takes about 3 weeks. In follicular lymphoma, the disease tends to be not growing particularly quickly. So 3 weeks is not really an issue. That's in contrast to some of the faster growing lymphomas where we sometimes have to do some additional treatment while we're waiting for the CAR T cells. And basically then the T cells are reinfused back into the body often in the hospital setting, or there often is a component in which people are monitored closely in the hospital for side effects. I think we can get into more details about the potential side effects in the question and answer session, because I think that is a longer discussion in and of itself. The other type of treatment that's similar to CAR T in a way is bispecific antibody therapy. And we have one approved agent now in the US with this type of strategy. And basically, it enables the B cells and T cells to be connected in a way that also helps the body better fight the lymphoma. One advantage of this is that it doesn't require this manufacturing step. So we often use the term off the shelf. Like if I want to use this treatment and it's for someone who has an FDA approved indication, then we can get an insurance authorization and we can administer it without having any major wait time. The downside of it is that it's not just one treatment like the CAR T cell, but it actually is often a monthly treatment initially, and then it's spaced out to monthly for, let's say, about 10 months or so. So it's roughly like a year-long treatment. And so it's a little cumbersome. The side effect profile tends to be a little bit easier, like it's a little bit less likely to cause some of these other side effects that we may explore more in the question and answer session. And so for that reason, I think the bispecific antibody I often favor for older patients in particular, because I think that they're less likely to have side effects with that type of drug compared to the CAR T cell therapy. One other agent, actually two other agents I want to mention. There is another oral drug called tazemetostat, which is called an EZH2 inhibitor. And this is an oral drug that's taken twice daily and generally is quite well tolerated. It usually can cause some mild fatigue and mild GI, gastrointestinal type side effects, but really does not have that many side effects, aside from having to take 8 pills a day, which I do think is pretty cumbersome. And then interestingly, there's a class of drug called BTK inhibitor that is really well known to us for years in other diseases that we treat, such as chronic lymphocytic leukemia and mantle cell lymphoma. And that drug is called zanubrutinib, was actually just approved in the last few weeks, along with obinutuzumab, which I've already talked about earlier, for follicular lymphoma. And that is somewhat surprising to us because we thought years ago that drug would work really well in follicular lymphoma, that type of drug, and it didn't in earlier versions, but now we have that as another option. So I want to just end with a mention of clinical trials before we move on to the question and answer session. Follicular lymphoma, because it is relatively slow growing disease in many cases, is a really remarkable disease to study in clinical trials, because often people can get access to new treatments before they would be able to get it commercially. So for example, and I'm going to tell you about Dr. Yamshon, because he's one of my good friends and colleagues, and I'm really proud of him. He's running a couple of clinical trials with combinations of these novel agents that is allowing us to have access to be able to get our patients, for example, the bispecific antibody, and I'm specifically going to talk about that, and he can mention the other trials if it comes up. But basically a bispecific antibody in combination with tazemetostat, the oral drug I just talked about, in someone with a new diagnosis of follicular lymphoma who's untreated. And so that's really exciting to me, because I'm hoping that type of treatment will become the standard of care at some point for patients who've been untreated, because we think that it may have a longer impact and also be safer for patients over time. And that's the way, basically, the way that so many new therapies have been approved for this disease in the last 10 years or so is because patients have been participating in clinical trials and have often been getting access to newer drugs before they could have gotten it commercially. And this is really changing the course of the management of this disease. And it's so fulfilling for us as doctors, taking care of patients, and also researching to be able to see such a dramatic change of available treatment options in such a short period of time. So thank you again. I'm really happy to be here, and I look forward to hearing your questions now.
Thank you so much, all of you, for sharing that. We really appreciate all of your minds put together to share kind of what your knowledge is. And now we will move on to the Q&A section. So there's a Q&A button in the middle of the bar, and if you would like to ask a question, you can put one in there. And then as we ask questions, any doctor can volunteer to answer, and it'd be great if you build on each other's thoughts or just discuss with each other. That's kind of why we like having you all here together, just to see kind of what you can offer each other. And so let's see, we have a few questions already on the chat. Someone said, are patients living for 10 to 15 years always on treatment? So is that, I think they're saying, is that everyone?
I
Anyone?
can answer that. I mean, I view that in a couple different ways, so I might not quite be getting at what you're asking. But one, I want to say many people live for decades on treatment. So, meaning, like, what I want to clarify is it's not like you need to be on treatment for that whole 20 years or whatever. Like you go, it's more like a chronic disease. So, let's say, we give treatment and then it goes into remission, hopefully for a number of years. And then let's say 5 years later, you get more treatment, you're on it for 6 months, and then it goes away. So sometimes some of these treatments we do continue as long as they're working. So a lot of the oral type therapies, but those tend to be better tolerated. So for example, this newer drug, zanubrutinib, that's approved, usually if people are on that, they will be on it, could be on it for years, but that actually has very minimal side effects. So, just to summarize, my two answers are yes, many patients are living for years for that decades long time period, and two, you are not going to be on treatment continuously. You would be on treatment intermittently as the disease acts up during that time.
Okay, perfect. Does anyone else have any thoughts on that? Okay. We can move on to the next question. I've heard follicular lymphoma can turn into more aggressive forms of lymphoma. How common is this occurrence? Is there anything I can do to prevent this from happening?
I can comment on
So
this.
go
Oh,
for it.
you can go ahead.
Go for it.
I mean, the numbers are variable depending on the sort of the data set you look at, but it's anywhere from 5 to 10, 15% over the lifespan of patients with follicular lymphoma. And there's been a lot of work trying to figure out if there are certain risk factors for this, whether it's in the pre-rituximab era, was it more common? If we treat disease now with immune therapy like rituximab, do we see this less often? It seems to be more frequently treated disease, multiple lines of therapy. You see a higher risk in patients who've had multiple relapses of this transformation, but that's not exclusive to that population. There's no great biomarkers, and this kind of goes back to Dr. Rutherford's point about trying to biopsy nodes that look like, at least on PET scan, maybe are the hottest, so to speak, or the brightest on the PET scan that might have some transformation within that node, and that might help clarify that question. So it's always in the back of our mind. It's not extremely common, and it seems to be more frequent in patients who've been treated multiple times.
Okay. Did you want to add anything, Dr. Yamshon?
No, I think Dr. Hilal covered it very well. I guess one thing that is critical is kind of to emphasize the point that to our knowledge, that there's I guess nothing that we can do to intervene upon that. And I get the question a lot from patients. Is there something that I can eat to prevent this from happening? Something I can do to my diet, something I can do for my lifestyle to prevent these things from happening? And the answer that I usually tell people is that the things that are healthy, I guess, irrespective of the lymphoma, are still healthy and are good things to do. And actually, we know that being active, eating well, actually is very predictive of outcomes in lymphoma in general. And so even though it doesn't, we don't know that that has any effect on preventing transformation specifically. It does, I think, help with being healthy in general, and then that by being healthy, it then optimizes outcomes.
I also want to make a point that I think this is often a source of a lot of anxiety and stress for patients, the concept of transformation. But the treatments that work, that we recommend in these situations, they work really well. So we have a lot of the same tools. I mentioned RCHOP. There's a reason that it's been the tried and true treatment for diffuse large B-cell lymphoma for decades. It works really well. I actually just had a patient who had a concern for transformation. I wasn't able to prove it, but I treated him, and now he's in a complete response. So even if that happens, we have really good treatments. The CAR T-cell therapy and bispecific antibodies are approved for diffuse large B-cell lymphoma, which is usually, if follicular lymphoma turns into aggressive lymphoma, it's usually diffuse large B-cell. We also have at least 4 other approved drugs that we haven't even mentioned in this discussion for diffuse large B-cell lymphoma specifically. So, I just try not to think about it too much. Obviously we want you to know that it's a possibility, but don't overthink it. And if it happens, there are lots of good treatments for it. So just know that, and just take it one day at a time, and don't dwell on that too much. Just as we're working hard to get these new therapies for follicular, there's as many, if not more, coming out for diffuse large B-cell, and there will continue to be so.
Perfect. Thank you, guys. Someone asked, how fast can you know if a treatment is working?
I guess I can take this one. I think that to some degree the answer to this question depends on the symptoms that you're experiencing before treatment. And so as I think we've discussed earlier, sometimes even for patients for whom we're treating, they don't necessarily have symptoms. And so if you don't have symptoms, it can sometimes be difficult to know if it's working without getting a scan. But if you do have symptoms, say you are having night sweats, or say that you are having some discomfort from a lymph node, one of the very satisfying things I know for patients, and also, I mean, for us as clinicians, is watching those symptoms evaporate in real time. And that, I think, is if the reason for treatment is having symptoms, you can actually track that and know. And oftentimes we will know well before the scan if someone has responded to treatment. I actually just had a patient recently who I actually treated with CAR T-cell therapy, who had very, very large lymph nodes. And we literally, when she was getting the CAR T-cell treatment, we would come in the room every morning, and each day we literally just would watch them shrink. And it was, it's something that you can really see in real time. And so I guess I would say that answer depends, but oftentimes you can see it happening even day to day.
To kind of add to that question, I did have a question from a patient earlier that said, if I'm experiencing general symptoms while on treatment, is there any way to know if it's from the disease growing or if it's from the treatment itself?
I think that so to some degree that depends on which treatment you're receiving, but a lot of the treatments that we do have sort of defined side effects that are common, that often differ from the symptoms that patients experience from their lymphoma. Rarely those can sometimes be overlapping, but otherwise I think that it can often be you can tell based on what type of side effects that people are experiencing. Other times it can be harder to tell if there's some overlapping symptoms in that sense. And so in those cases it can be a little bit harder, but I think for the most part, the symptoms that you're experiencing prior to receiving treatment you'll be able to tell if the quality has changed or if it's worsening of the same symptoms that you're experiencing prior, if I'm making any sense.
Yeah, I think that makes sense. Did anyone have anything to add before I move on? Okay. Michelle wanted to know, can I keep seeing my general oncologist, or do I need to see a follicular lymphoma specialist such as one of you guys?
I guess it depends on the situation. There's patients with follicular lymphoma who come for second opinions who have had maybe one line of therapy or no therapy at all and have been observed for a long time. And, you know, the, the, the trajectory of their disease indicates that they're going to be observed for many more years to come. Or if they do need treatment, it might only be something short course, standard treatment that's available. In those cases, I think it's very reasonable to see their general oncologist with regular follow-up. It's the most common indolent lymphoma. It's second most common lymphoma in general, and so a lot of general oncologists are very comfortable following patients with follicular lymphoma. So I think that's a very reasonable approach.
Okay.
I would just add that I actually have a number of patients who mainly have a doctor closer to where they live, but I'm available if something were to change. And so I think if you had any sense of wanting to, and there was another facility that's not too far for you to get to, I think it's totally reasonable just to go and have someone else available. I can actually address the question about at what point is it important to consider enrolling on a clinical trial, kind of hand in hand with that. So, yeah, I would say if you're at a point where it seems like you might need a new therapy, or if you're have a new diagnosis, I think it's always a good idea to have someone else. I mean, I would do it myself, honestly. Like, we live in a city in New York here where there's like 5 different hospitals, or more than that even. And so it's easy for that to happen here. I know I'm from Virginia, in a smaller place. I know, like, it's not always so easy, but I think that going and actually having your pathology slides reviewed by an academic center is a good idea, to make sure that group concurs with the diagnosis. You can also always ask your doctor to have, if it's a challenging case, we sometimes send cases to the NIH to be reviewed if it's sort of not a straightforward situation. And with regard to this clinical trial question, as I've said, I think some people have the idea that clinical trials are really just like if you've had many more treatment lines and that you need something different that's not available. But now, like, we have really good trials even for people with new diagnoses. So I would just, I think it's a good idea, if it's not too cumbersome for you, to actually at least go get another opinion, even if you plan to stay with your doctor, because that's actually a very good model for this disease, to have a doctor who is taking care of you close to home, but then have another person available if there's some nuance or some new treatment that's available that you might want to consider getting.
Perfect, thank you. An anonymous attendee asked, I could not tolerate Rituxan infusions. I had every reaction and side effect, now being treated with Revlimid. Is Revlimid helpful alone?
I would say that Revlimid is probably best studied in combination with rituximab, but we know that Revlimid is helpful in and of itself, and in clinical trials at our center that we've had with lenalidomide and rituximab, there was a subset of patients, especially in the COVID era, who had to stop the rituximab portion and still continued to have excellent responses on the Revlimid. And so, while there's never been a clinical trial of just lenalidomide, Revlimid, it definitely, I think we know, has efficacy in and of itself.
Anyone else
I,
have anything to add? Oh.
I would just add a couple things about the Rituxan. I usually try to dig really deep into figuring out what is the reaction and how bad was it, and what are these side effects exactly? Because there is sometimes situations where we see people kind of get labeled as having rituximab allergies, which, often is really common and expected, especially the first time around, and then they never get rituximab again. And it's a really effective therapy for follicular lymphoma. So if this is sort of an anaphylaxis type reaction, then, and we can prove that that's really what happened, then I think that's fair to say, well, we don't want to expose that person to rituximab again. But if there are other types of reactions that could be mitigated, side effects that could be mitigated, there are different strategies we could look into. And, I've had patients that I admit to the hospital for rituximab, and you just give it very slowly over 24 hours. It's not going to be an outpatient infusion, but if it's the only way to get it administered safely, sometimes that's important. I also think switching to an anti-CD20 antibody, a different kind, may be reasonable. We don't always see the cross reactions with obinutuzumab, for example. And if you get that approved, that can be something you can try as well.
I completely agree with you, Dr. Hilal. I just had this actually happen to me with a dear patient who's young, and we really want to give her the I tried rituximab, and she really was having anaphylactic type reactions, like almost immediately after starting it. And what we did actually after talking to some colleagues is give a very high dose of dexamethasone, which is a steroid that we don't always use as a pre-medication for this, and giving it intravenously an hour. Like, we watched the clock and made sure that a full hour had passed. And like, now it's been 3 weeks. We got the obinutuzumab safely in her, and I feel so much better now as her doctor that I'm going to be able to add this drug onto it. I agree with you that I think we should try. But that being said, I have also had other patients who were on Revlimid, lenalidomide as a single agent, and I absolutely think that it works by itself too. So if that's not an option for you, the person who asked the question, you are still going to get benefit. But I completely agree that we should try to give another agent or do it in a different way to try to get it in these types of situations, if at all possible.
Thank you for that input. Rebecca asks, are there precautions patients should take to mitigate the risk of infection when doing maintenance rituximab treatments?
I feel like I should address this because I'm the one who brought it up. So I want to tell you that I didn't mean to overly scare you about risk of infection on rituximab. It's certainly, like, compared to chemotherapy, which does have an increased risk of infection because you're causing the blood counts to go down temporarily. This is a milder immunosuppression. So what I would say is, I think there is a role. I mean, I have occasionally done it, so I'm not saying that, I think there are times when it's a reasonable strategy. So what I would do is I would stay up to date on vaccines such as COVID, RSV. I personally had RSV and it was horrible, and I have a normal immune system. So I have little kids. So I'm telling you that I believe that that it's very important to get the vaccine if you're immunosuppressed. That being said, you may not mount an adequate response to the vaccines because of being on rituximab. So I think you just need to be more cautious, like, particularly, I mean, thankfully we're coming out of the winter and you'll be able to be outside more. I think the biggest risks are in the fall and winter when people are inside a lot and, at risk, there are more viral infections going around. But I would say, if you're going to be in close contact with a lot of people, consider wearing a mask. If you have little children or your family has little children, grandchildren, et cetera, I would just be a little more cautious to be around them during, especially during that high volume season of viral infections, because you would be more likely to get it and to have a more severe infection. But I don't mean, it's okay to do maintenance. The reason that people do it, that doctors recommend it, is because it can increase what we call your progression-free survival, meaning the amount of time before you would need another therapy. But it's never been shown to make people live longer. And so that's why we typically don't do it at our institution. But again, I'm not trying to, the bottom line with follicular lymphoma is that there are many different ways to manage it, and there's not one right answer. And every person really needs the treatment tailored to their exact situation. And so, you just need to be cautious of your risk that you may be more likely to get infections, and then just be aware and try to minimize your contact with people who are sick.
Thank you for that. Megan asks, who should I reach out to help mitigate the side effects of treatment?
I think that it's absolutely critical to the treatment of follicular lymphoma in general, to be in very close communication with your oncologist who's giving you treatment, and not just necessarily on when you're receiving treatment, but I actually think throughout the process, and feeling like you can have open lines of communication, whether you are in a stage where you are doing watch and wait and you're having anxiety about, waiting, or whether you are receiving treatment and having side effects. I think having very open lines of communication with the doctor that is doing your treatment is absolutely critical. And so, ultimately, I think that they are the ones who know you the best. They are the ones who are giving you the treatment. And so, that relationship, I think even outside of stages where you're getting treatment is so important. And so I think that you should definitely feel like, I encourage my patients actually all have my like personal email address, and they reach out to me for for any little thing, which is but I think that that's critical, right? I think that that is very important, that patients feel like they can have those open lines of communication, and that if they're experiencing a side effect, that it can be acted upon. And because in the vast majority of the time, if you're having a side effect from treatment, there's something that your oncologist can do to mitigate that, whether it's prescribing a new medication, whether it's reducing the dose, whether it's there's always something that can be done. But the only way that your oncologist can do something is to know about it. And so, I think that communication is probably like I think in lymphoma in general, but especially in follicular lymphoma, like maintaining those open lines of communication is critical.
Thank you for sharing that. Any other thoughts? One thought I had is, I don't know about your clinics, but I worked at an oncology clinic before this, and they had a specific palliative care doc that went to all of our clinics and visited really any patient who needed symptom management. So I'm not sure about every clinic, but I know that there are resources available like that. One more question from the audience is, given that follicular lymphoma is not curable today, how is remission and no evidence of disease defined?
I think this is a really common question. People think of remission as a certain, I guess, in a different way than we do. So what I tell patients is, cure is really a function of time. So we can determine remission at a certain time point, and there's a partial remission where you have sort of reduction in the disease but not complete eradication. So you can see it on the scan still, but it's smaller than it was before you started. And there's complete remissions that may be where you just don't see it on the imaging anymore. You don't see it on the bone marrow biopsy if it was in the bone marrow to begin with. And so probably no evidence of disease and complete remission are sort of similar, synonymous terms, but you can have a partial remission and still technically be called in a remission. But we know you have the disease, but it's just not causing problems anymore. We partially treated it, and it may stay that way for a while. Cure, as we said, follicular lymphoma is probably not curable yet, but cure, if you live 10, 15 years without having follicular lymphoma and you die of something else, you could theoretically say you were cured of follicular lymphoma during your lifetime. I mean, it's one of those things where we always anticipate it's going to show up at some point, and we can deal with it. But it's not something that I would think of as, you know, there's competing risks, and I think there are other diseases out there that can cause problems, and so we don't like to use the word cure. And I think remission is sort of a good way to think about it, and it is a temporary state. That's probably how I would frame it.
Thank you for that.
I would just like to add, like from an objective standpoint, we often use PET scans because that gives us a number of metabolic activity. And basically on every PET scan at the top, there should be, like, I view it as kind of like a key, and it'll tell you the liver. To me, the most important number is the liver uptake. And that doesn't mean that you have lymphoma in your liver. It means that the liver takes up a certain amount of this glucose that's injected in PET scans. And the number, it depends on the scan, but it's usually somewhere in the 2 to 4 range. And so to be considered a negative PET scan, and that there's a scoring system that I'm not going to go into, but basically you need to have the score around or below the liver for it to be considered a complete response. And so, like, often what I'll say is, like, you're in remission, or you don't have any evidence of disease on this scan because the activity of the lymph nodes are all below the liver. But then, like Dr. Hilal said, and Dr. Yamshon, I think, concurred, that we do know in this disease that it's going to act up again. And there are times when, even if the numbers are higher than the liver, but they're better than they were to start, we would still, knowing someone may still have some active lymphoma, but they've responded, we still may monitor them with an active surveillance approach, and continue to watch them very closely.
Yeah. I think you really both hit the nail on the head. I guess I'd want to add a small piece, which is that, to me, even in other types of lymphoma that we call them curable, cure is something that I think can really only be assessed almost in retrospect, right? So you get a PET scan that shows no active disease. So the PET scan looks completely normal, but we don't know whether there's, like, microscopic cells that are there that we just can't see on the scan. And the only way to know if it's going to come back is if it comes back. And so I think that makes things a little bit difficult. One of my mentors, and actually one of Dr. Rutherford's mentors also, Dr. John Leonard, describes follicular lymphoma. He likes to call it a hitchhiker, that it's something that is with you, and it's something that we can, the goal is to drive across the country over the course, if we think of our life as driving across the country, the lymphoma is a hitchhiker that's in the car with you. And it's something that we can, when it starts to cause problems, we can kind of, like, push it into the trunk or into the back seat. But it's really tough to kick it out of the car. And even when it's there and you're not noticing it, it's still there. But as long as we get to the end of our trip in one piece, and we make it to Disneyland or wherever we're trying to go, then that's the goal. And it's okay that there's this hitchhiker still in the back with you. And so I've think found that kind of a useful framework to think about it. And I think, as Dr. Hilal says, the goal is that we die with follicular lymphoma, but it's not something that it's something that we have over the course of our lifetime. I sometimes even describe it to patients as almost like, I try to think of it as something like diabetes or high blood pressure, that it's something that we try to manage over time, and that we can push it down but never get rid of completely, if that makes any sense.
That's very helpful. Thank you. All right, I think we'll end the Q&A for today, since we only have a few minutes left. Before we go, I'd like to mention one of our important programs called HealthTree Cure Hub. At HealthTree, we believe educated patients and researchers create better and faster cures. HealthTree Cure Hub empowers patients with the knowledge they need to actively participate in their health journey while providing researchers with valuable insights from real-world experiences like yours. We invite you to join the 12,000 and counting blood cancer patients who are currently impacting their outcomes while accelerating research by participating in CureHub. CureHub is a one-stop platform that provides the ability to connect to surveys and studies submitted by follicular lymphoma experts, securely connect your medical records and track your disease within one interface, discover clinical trials personalized to you, anonymously connect to your genetic twin matches, and lastly, gain access to a database of side effect solutions provided by other blood cancer patients. You can enroll in this platform by visiting the link at the bottom of this page. And as a reminder, our next follicular lymphoma event will take place April 12th. This will be a pre-recorded podcast, so questions from the audience will need to be submitted by April 10th. And there will be another podcast on May 6th. This will also be pre-recorded, and questions will need to be submitted by April 25th. You can register for any of these events at the link on this page. And once again, thank you to our doctors for taking this big chunk of time out of their day and joining us. Your knowledge is so valuable and we really appreciate it, and our patients really appreciate it. And we'd also like to thank our sponsors, Regeneron and Bristol Myers Squibb, for making this event possible. And thank you everyone for joining to help us build a stronger HealthTree community for follicular lymphoma. And please don't hesitate to reach out to me if you have any questions. My email is kat@healthtree.org. And I hope you all have a great evening. Thank you, everyone.